Welcome, welcome. We're early, a minute early. It might be a new day in my life. Dr. Kittleson, you're a good influence on me.
Oh, I'm delighted. Thank you.
We were just chatting up children, thinking how wonderful parents we are.
And that's
We,
exactly what we were talking about. I concur.
that's what I was talking about. Generally, anybody that knows me knows it's not true. We'll give people a few minutes to get on, but I'm Adrienne Wood. I have Tales of an Educated Debutante, and I'm super excited to be here tonight talking about HCM. Today's session was developed by MedIQ and is supported by an educational grant from Bristol Myers Squibb. And I have a new friend on, very excited to have her, Dr. Kittleson. And she is going to introduce herself, and we're going to have kind of a Q&A discussion, which really makes it fun. I'll ask questions, and then if people want to put questions in the chat, we may have time to get to them, which is always nice. So really, I think tonight we're going to talk, and I'm going to let you talk, Dr. Kittleson. I'm just giving them a little heads up. So HCM, hypertrophic cardiomyopathy, or HCM, we are going to be kind of going over common questions for people that might say, do I know what that is? Do I need to know what that is? And hoping to promote conversations on the importance of knowing more about the signs and symptoms of HCM, when to see your clinician, the importance of knowing your family history. So welcome tonight, Dr. Kittleson. Please introduce yourself to us.
Thank you so much. I'm delighted to be here. So I am a professor of medicine and cardiology at the Smith Heart Institute at Cedars-Sinai in Los Angeles, California, with particular expertise in hypertrophic cardiomyopathy.
Okay. And it's 4:00 where you are. Right?
Yes, so I'm ready and energized. Can't wait to get started.
And I've just told my whole family, do not come in this kitchen until 8:30. No one will starve. We're in a good place. My office is near the kitchen. I told her that. So pardon if you hear jingle, jangling, or an autistic person who wants ice cream, because you just never know what might happen, Dr. Kittleson. So just prepare yourself.
Listen, I'm prepared for every emergency. I'm a cardiologist.
Oh, good. Well, I need you in my life on the daily. Many people might be listening tonight and being like, I don't even know what HCM, does this apply to me? So can we just start with a description of HCM?
Yes. So HCM, or hypertrophic cardiomyopathy, is a condition where the walls of the heart are thicker than normal. That's what hypertrophy means, thickening of the heart walls, without a clear, understandable underlying explanation. And it is a genetically mediated condition. So a genetic disorder where the heart muscle is thicker than normal. That defines hypertrophic cardiomyopathy.
Okay. What are the typical signs and symptoms of someone who has HCM?
So, someone with HCM may present to medical attention in a number of different ways. So, as I mentioned, it's genetic. So, some people have a known family history, and if so, they come in for screening ultrasounds of the heart or echocardiograms that may uncover that the walls of their heart are thicker than normal. So, that's one way. The second way is they feel great, but they show up to their doctor for a routine examination. And as part of that examination, someone listens to their heart or gets an electrocardiogram, and there's an abnormal heart murmur when they listen, or the electrocardiogram looks abnormal, which then funnels again to the ultrasound or echocardiogram, which can make the diagnosis. The third way is symptoms. Now, there's two types of symptoms people can present with. One would be chest discomfort and or shortness of breath that's limiting activities. And a typical for physicians, you go to a physician, you say, I have chest discomfort or I have shortness of breath and it's impairing my ability to exercise. You end up with an echocardiogram. There's a theme here, and the echocardiogram then can make the diagnosis. The second way people can present with symptoms is much rarer, but far more dramatic. It would be an episode of cardiac arrest. And after an episode of cardiac arrest, the goal is to figure out why. Why did the heart stop beating? Why did this patient require CPR? Which will lead to an echocardiogram, which may uncover this thickening of the heart muscle consistent with HCM.
Okay. So I'm going to ask you just a little side question. We were just talking, I have 3 teenagers. They're all play sports, very active. And so for a parent who is, tonight I went to my son's soccer game. What would a parent say? Well, how do I know if my athlete, what are some signs and symptoms that, because you might get out of breath if you've run sprints, but for a healthy 17-year-old?
Yeah, it's such a great question because while it is relatively rare to have one of these events with exercise, when it's your kid, you want to make sure you've crossed every T and dotted every I. So the most important thing is they have their annual physicals with their pediatrician, and the pediatrician will diligently listen to their heart with their stethoscope and ensure that they hear no abnormal heart sounds that would be concerning for HCM. Now, you could ask, well, what about other stuff? Why doesn't every athlete get an electrocardiogram? Why doesn't every athlete get an echocardiogram? The problem with that approach is you're almost more likely to find stuff that doesn't mean anything than stuff that does, which is why the yearly physical with the pediatrician is hugely important to listen to the heart. And then for your kid, the key here is there anything that's different? Meaning, yeah, I always get short of breath when I run sprints, but it's getting a lot worse. I can't run the sprints like I used to. And the other red flags I like to pay attention to, I feel like I'm going to faint or pass out. And there was no reason why I should have. It wasn't super hot. I'd had enough water. That's kind of weird. That doesn't make sense. Or I feel my heart racing and pounding, and I wasn't even pushing myself that hard. So symptoms that don't make sense or easily explained by what you'd expect to feel when you're exercising. So extreme shortness of breath out of proportion to what you're doing, or that's worsened so you can't do what you used to do. Palpitations when you don't expect your heart to be pounding, fainting or near fainting when there isn't some easy explanation like you were just dehydrated. But if as a mom you hear that stuff, you call the pediatrician.
Right. Well, that's really good to know. And it reminds me to talk to our kids about it too, of how they're feeling. I think we know, like, if you're going to throw up, if you have a fever, if your throat hurts, give me an alert. But that is a really important conversation. So you mentioned there's kind of a family history. What are the other risk factors?
Amazingly, it is purely genetic. So while every cardiologist, every doctor will tell you you should eat right and you should exercise and you shouldn't smoke and don't drink too much alcohol, you should still do all those things. But that really has nothing to do with hypertrophic cardiomyopathy. It is a genetic condition inherited through your mom or your dad. There could be a 50% chance if mom or dad has it that you have the gene too. Now, what's so interesting about these genetic conditions is that genetics aren't destiny in the sense that you might have the gene and have super mild symptoms or never get any symptoms, but your mom might have had more severe symptoms. You can't pin it all on genetics, but it's not like, say, you've been diagnosed that if you just take this vitamin or this supplement or walk for 30 minutes a day, you're going to change the particular history of the HCM. Now, you'll still be healthier and you'll still be better and you should do it, but it's not like you can change what the HCM will do in your heart.
Okay. So let's move on now to the next generation of my family, my parents. And let's just say that and this could happen in a lot of areas of conversation that we're not going to talk about tonight, but let's just say that my mother is like, your dad just doesn't seem like he's as good. But my dad says he's fine. But my mother's like, I don't know. He doesn't seem like he can walk as far as he used to. How do you navigate that conversation?
It's fascinating. HCM being a genetic condition means that essentially you're born with it. Now, it typically doesn't present or its symptoms don't occur or the heart doesn't look abnormal until adolescence at the earliest. And the typical age at which people start to have symptoms is 20s, 30s, or 40s in most cases. It's highly unlikely that symptoms would appear for the very first time in someone in their 60s, 70s, or 80s. So the good news is, if you're lucky enough to reach those ages, and you start to have symptoms, it's very unlikely that hypertrophic cardiomyopathy is the culprit, which makes it all the more important to be aware of this because it is a condition of younger people. So a young person shouldn't feel short of breath when they run up a flight of stairs. So if they do, it should be a red flag to go to your doctor and say, I'm too young to have these limitations. What could be going on?
What is the earliest that you can diagnose it? Age?
So the thickness of the heart muscle is typically set around the time of adolescence. So while it can be diagnosed in children in some situations, say mom or dad has it and you want to start screening, children will start screening with an echocardiogram every 5 years, some interval, and continue to have those echocardiograms really up until middle age, like around 50, just to make sure you haven't missed any late presentations. Yeah, hooray for 50. Me too. Yeah. But really it can start young. So if you have the opportunity through a known family history to start testing, you start testing. An echocardiogram is great in that it involves ultrasound. It's non-invasive. There's no radiation. There's no dye or contrast. It's a very easy test to do, very straightforward to interpret. And then that would proceed until middle age in someone who has a family history. Now, genetic testing is also possible. That can there's nuances there to genetic testing and then screening echocardiograms. But really, if you've reached middle age and your echo hasn't shown any signs, chances are you don't have it.
Okay. Yes, we in the comments, Donna is saying her 34-year-old has had it and was diagnosed when he was 13. So that goes right along with kind of what you're saying. What are the risks of undiagnosed or untreated HCM?
So, the two major problems people run into with HCM are the chest discomfort and shortness of breath that limits activities, and then the abnormal heart rhythms that can lead to cardiac arrest, or what we call sudden cardiac death. Let's take the chest discomfort and shortness of breath first. I mentioned the echocardiogram as absolutely pivotal to make the diagnosis of the condition by looking at the thickness of the heart muscle. And there's actually two flavors of HCM that you tell the difference based on the echocardiogram. It's called obstructive and non-obstructive. Obstructive is sort of a weird word because people think, oh, I have an obstruction, I have a blockage, but it's not that kind of obstruction. It's a term to describe that the heart muscle is thicker than normal in such a way that it's hard for the blood to be pumped out of the heart, which then leads to symptoms of chest discomfort or shortness of breath. If you have non-obstructive HCM, the echo showed you that, you can still have symptoms of chest discomfort and shortness of breath, but it's a bit of a different reason, which means the medications you may give are different. So first reason it's important to diagnose it and not ignore symptoms is if you have chest discomfort and shortness of breath that's limiting your activities and you're in your teens, 20s, 30s, when you don't expect to be having these symptoms, you want to go see the cardiologist. You want to get the echocardiogram. You want to define if you have HCM and if you have obstructive versus non-obstructive, because there are medications that can improve quality of life, potentially other interventions. So the first reason is to maximize quality of life. The second reason is based on the second problem, which is these abnormal heart rhythms. So while cardiac arrest and sudden cardiac death is overall quite rare, maybe 2 to 3 out of 100 people with HCM would ever suffer from that. It's something that could be devastating if it occurred. So to know you have the condition, to have the appropriate risk evaluation to prevent future sudden cardiac death is hugely important. So the reason to not ignore symptoms is you can improve your quality of life and fix the symptoms if you get the right diagnosis, and you can improve your longevity by getting under care. Back in the 1970s, people with HCM had decreased survival compared to people without HCM. In the current era, survival is exactly the same. You can live to the age of 100 with HCM. Survival is not compromised by this condition because we have so many amazing ways to treat it. So you need to get a diagnosis to get the right treatments.
Right. Survival with treatment.
Correct.
Not just survival. I don't like to go to the doctor. I'm not going to the doctor. I'm fine.
Well, I mean, it's nice to think that way, but thinking doesn't make it so.
This is a very good point. What advice would you give to somebody who says, well, maybe they're sitting here right now thinking, well, am I short of breath? Am I short of breath? I'm 25. Maybe I'm just out of shape. What should they see a clinician? Or what should you do? How do you know?
Yeah, it is a good question because there could be 100 reasons why someone's short of breath. Maybe you have some allergies or some asthma, or maybe you're deconditioned, out of shape. I mean, true, there's a lot of things. So how do you distinguish what's okay, I just feel like this because I don't exercise, where I feel like this because something's not quite right? Number one, sometimes the trajectory helps, meaning I used to be able to do this and now I can't. That's a red flag, right? Like I used to run up the flight of stairs like everyone else runs up a flight of stairs. And now it's like my colleague at work who's twice my age can do it and I can't. I mean, that's weird, right? So a change in symptoms always warrants medical attention. Maybe not urgent, you don't have to rush to the ER, but you call up your primary doctor and say, there's been this change and I don't understand why. The second is kind of comparing yourself to other people your age. Like, why can everyone else my age do this and I can't keep up? Is there another reason? So I think, the worst thing that happens is you go to the doctor and they say, we've done all the tests and you're fine. That's okay. I like to tell patients it's not your job to figure out if there's something scary going on. It's my job. You got to come to me to dissect the severity of your symptoms. But a change from prior in the wrong direction, worsening symptoms, and you just doesn't make sense to you that you can't do stuff your colleagues of your same age can, then it senses something may be wrong.
Mm-hmm. And you would go see your primary care physician. It's not like you're like, I have to make an appointment with a cardiologist.
Yeah, no, absolutely. I mean, I think primary care physicians are the unsung heroes of the medical establishment. They are extraordinary in their ability to parse out serious or not serious, normal versus abnormal. And they may tell you, try this and let's see if it helps. Try going back to regular exercise and seeing if your symptoms get better because you stopped exercising. You probably just a little out of shape. Go back to it. Or they might say, you know what? I don't like the way this sounds, the way your heart sounds. Let's do further testing. So I think that starting point of calibrating the medical urgency or concern with your primary care physician is hugely important.
Yeah. And I think your point earlier when you said, your annual exam, I think when your children are little, and maybe I'm just speaking for myself, but, you go every year, you're just because you're having to go all the time. And then as they get older, it's easy to just kind of be like, well, they look fine, they're fine, and not go. And so that's just another reason of going and kind of having a baseline too of somebody knowing you well.
Yeah, I think there's no substitute for that. I mean, when the kids are little, there's all those school forms that got to be filled out every year. But right, when they fly the nest, as best as you can convince them that a yearly checkup is just quick, once a year, doesn't take that much time, as best as you can control what your grown-up children do. I think it makes a huge difference.
Well, it's really nice at our school system. They do them for sports and they'll do them at school. And actually, they caught my daughter's scoliosis that way, which,
Wow.
I was like, oh, how'd we miss it? But, that's another story. But so it's great to, when you're involved in athletics, kind of that's happening on its own too, because you've got to have those checks. So when you talk about, this might not, no question is a dumb question, but this is a dumb question. If something is hereditary, it has to start somewhere. So it can't always be hereditary, right? Like, couldn't there just be somebody that just pops up with it?
Yeah, that's a phenomenal question. It really gets to so much about genetics, right? Okay, so yes, we know that there is a genetic mutation in one of the proteins of the heart muscle that is responsible for the development of HCM. But here's the thing about genetics. There's a lot of genes we just don't know. We don't know exactly how they work or what they do. So even if you take someone with HCM and they've got a clear family history, it was their mom and their mom's sister and their maternal grandma and their cousin on their mom's side, and all of them have HCM and they have HCM too, and then you do genetic testing, it comes back negative, it just means there's so many genes we don't know. So there's that piece of it. And the second piece, exactly as you mentioned, yes, there are people that pop up out of nowhere with HCM, but no one in my family has ever had it. There could be like a spontaneous mutation that they were lucky enough to now get a mutation in it that wasn't passed along through the family. The third possibility, again, there's so many nuances, is that two people, identical twins, who have the same mutation, one could have barely any symptoms and one has a ton of symptoms. One's echo looks barely abnormal, one's echocardiogram, the ultrasound of the heart, looks completely abnormal. There's some genetic environmental interactions we just don't understand. So really, anyone who has a diagnosis should get genetic testing, because it's very helpful then for family members who might want to know if they've inherited it to check. But only about 30% of people who undergo genetic testing have a positive test, which doesn't mean it's not inherited. It just means we don't understand all the genes that cause it.
And when you say family members, so what if your first cousin had it? Like, how far out do you go to get tested?
Oh my gosh, you asked the best question. So here's the thing, and there's an art to taking what we call a family history, because to a lay person, my uncle, my cousin had a heart attack. My uncle had a heart attack. What is heart attack mean? To me, as a cardiologist, that's a very special definition. It means a myocardial infarction caused by atherosclerotic acute thrombosis of the coronary, which is not HCM. To a non-cardiologist, to a non-physician, a heart attack just might mean they drop dead suddenly, right? So I think, so for me, it's when someone says, my grandma had a heart attack, I'm like, tell me more. What do you mean?
I'm glad you do that and not interrupt you, because I call basically any heart thing, I've called it a heart attack.
Right, because it's an all-purpose term for something serious to the heart happened to my relatives.
Like, oh, they had a heart attack. You're like, really? Did they?
So how do you tease it out more? You tease it out by asking, and you can ask your family members this, if you're trying to figure out what happened to grandma or your cousin or your aunt. So were they had carried this like diagnosis for a long time, and they went to the doctor, and then they kind of dwindled and they passed away, and when they were 80, okay, that sounds kind of like old age and kind of garden variety heart problems. Did they just drop dead suddenly and no one knew why? Oh, that's much more concerning, because that could have been a heart attack, but it could have been something like a sudden cardiac death episode. And here's the subtleties we dive into, like I dive into when I see patients. I say, did anyone in your family have any weird kind of death? Like someone who was a really strong swimmer who drowned while they were swimming. That could be a sudden death episode. They had some kind of event, arrhythmia, cardiac arrest while they were swimming, and no one could explain it. Or did you ever have a family member who was driving the car, and got into a horrible car accident and died, but it was like they hit a tree or they went off a bridge and no one could figure out why it happened. There wasn't ice on the road. So did they have an arrest behind the wheel of a car? So there's kind of different ways to get at what's a concerning family history. And exactly as you said, the key is to take what we call a 3-generation family history. So brothers, sisters, parents is not enough, because sometimes 2 people have the gene and one person shows symptoms and some doesn't. So you try to go back farther. So you ask parents, grandparents, aunts, uncles, cousins, kids, getting at any heart history. And then when you say heart attack, what exactly did that mean? And then what about any weird things like drownings or car accidents that didn't make sense? And there you can sometimes, when you delve deep like this, you put together quite a concerning pattern of events that previously weren't recognized to be tied together.
Oh, that's really interesting. Yeah. And a good way to just talk to I was just sitting here thinking like, okay, my father-in-law who died last spring, not of, but he had a lot of heart things. But I need to know more about what those things were, because I didn't know to think, okay, is this something that we need to be looking at for our family? And are there other inherited conditions besides HCM
Oh, yes. I mean, there's many
in the
related to the
heart?
heart. Absolutely.
Okay.
So, like if someone has had said stents or bypass surgery, which would be like coronary artery disease, a atherosclerotic process, completely different from HCM and independent, that you'd want to know, well, what age were they when they were first diagnosed? And if you tell me 70, I'll say, okay, great, that's just life and environment and, but if you tell me 30, 40, 50, all of a sudden I'm very disturbed because it's not normal to get it that early. That speaks to something potentially genetic. So there's a lot of details that you need to sort out to figure out if family history affects personal risk.
So somebody has said it's this kind of scary for us, but when you talk about treatment, is this? It doesn't feel scary to me, I guess, because I feel like you're saying if you're treated, what is treatment like?
Yes. So the first thing I'd say is this: listen, life is scary. And we have to, I think the best philosophy is you don't worry, you make a plan. Meaning, if you have these symptoms and you decide to ignore them, I agree, that is scary. But if you have these symptoms and you seek an appointment with your primary doctor to discuss the next steps, you're not worrying,
Yeah.
you're making a plan. So really, and as I said, with treatment, people with HCM live exactly as long as people without HCM. So this is not a condition that you have to worry is life threatening if you get the proper attention. So what is it? So medications, there are medications that if you have particularly the obstructive HCM seen on echocardiogram that is causing the chest discomfort and shortness of breath that is impacting your quality of life, there's an array of medications that can help you feel better, maximize your quality of life. When medications fail, there are invasive interventions that are hugely successful. So that's really amazing. And then when you've got the concern for the sudden cardiac death or cardiac arrest, there are interventions to prevent death, to keep you feeling good, staying alive, free of these dangerous rhythms. So I think there's cause for huge optimism that as long as you pay attention to your symptoms, you address your symptoms with your physician, that you will live a wonderful life. But the key is don't worry, make a plan.
Right. Make a plan, which is so important on so many levels. Well, Dr. Kittleson, this was really informative, and I walked away learning something, which is always good for me because I'm not a doctor. I just play one on television.
I'd
Like
like that. That sounds fun. Actually, my job's probably easier, so I'll keep it.
no, I don't think so. Like many of my viewers. So we really appreciate everybody watching. There's a great discussion, and I have a survey, and after this, I will put it up in the comments. And everybody take the survey, and you have a chance to win $100 gift card. It takes a few minutes. Just trying to always pull in information about HCM and help folks. Now there is one more question. Okay, I'm just going to let one little question come in here. Those in menopause or perimenopause have all kind of discomforts. How is should they be particularly aware of what's happening?
Yeah, great question. I feel you on that. Yes, I have medical and personal experience with what you're talking about. There is no relationship between HCM and perimenopause or menopause. HCM typically presents in younger people. You'd be less likely to say that symptoms occurring in the perimenopause area could be potential HCM. That being said, anytime you have a change in your exercise capacity or exert tolerance or stamina or energy or endurance, or you feel like you can't keep up with people you used to be able to keep up with, that's a time to go to the doctor. And it might be 17 things and not HCM, but it's better to know about it so you can maximize your quality of life and your longevity.
I'm in. Well, thank you again. Much appreciate MedIQ for hosting us. And thank you, Dr. Kittleson. I hope I'll get to see you again soon.
Thank you. It was so much fun.
Okay, bye, everybody.
Bye.